All right, so hi everyone, welcome to tonight's Doc Talk on SBRT for colorectal, liver, and lung metastases. We're so excited to have Dr. Eric Miller from The Ohio State University Comprehensive Cancer Center with us this evening. He is an amazing radiation oncologist. I know some of his patients in Colontown speak so highly of him. I've had the pleasure of meeting him at ASCO and also hearing him speak on the Erasure trial, which I think he's going to talk about a little bit this evening as well. So we are thrilled and honored to have you here this evening. Thank you for taking time away from your work and your family to speak to us and educate our patients and our families on this extremely important topic. And with that, Dr. Miller, I'm going to turn it over to you.
Yeah, thank you so much. Thank you so much for the opportunity to be here and to spend some time with you all and talking about SBRT for colorectal, liver, and lung metastases. So just to kind of hop into it, here's my outline. I'm going to try to cover a decent amount in the next 45 minutes or so. Leave time for questions as well. So first, to kind of get us all on the same page, talking about local therapy modalities. Then I'll talk about the definition of oligometastatic disease and how that applies to colorectal cancer. Talk a little bit about colorectal cancer patterns of spread, and then liver confined metastasis and management, lung confined metastasis and management. And then go into more detail about what exactly is SBRT. Then I'm going to go through a step-by-step treatment for SBRT, some of the potential side effects of treatment, and then that will kind of go into what more extensive disease and how we manage that, and then the ongoing Erasure trial as kind of to finish the talk. So first, to get us all on the same page, I wanted to talk a little bit about local therapy modalities. Now, I think most people are kind of familiar with all of these, but just to kind of get us all to the same baseline. So of course, there's surgical resection, where there's physical removal of the tissue through an invasive mechanism. There's thermal ablation, which is whenever a probe is placed in the tumor and either heat or extreme cold is used to ablate the tumor using the thermal methods. And then finally, there's SBRT, or stereotactic body radiation therapy, which uses high doses of conformal radiation therapy to ablate a tumor. So those are all different local therapy modalities. So to define oligometastatic disease, the root word is oligos, which means little, smaller, few. And in the mid-90s, Hellman and Wishelbaum wrote an article in the JCO which described metastatic disease as a spectrum. And on one end of the spectrum, you have a large burden of metastatic disease on the far right. On the other end of the spectrum, you have a limited number of lesions. And they define this as oligometastatic, meaning a few lesions. And biologically, we think that this type of disease may behave a little bit differently. It may behave more like a locally confined process rather than a widely systemic process. And if you have a limited number of lesions, it's possible to do local therapies like surgery, ablation, and radiation. And by doing these local therapies, including all three modalities, you may result in prolonged disease-free survival and even potentially cure in some patients. And colorectal cancer is really one of the poster children for this oligometastatic concept, particularly for oligometastatic colorectal cancer in the liver. So just to kind of give you some numbers, so about a quarter of patients with metastatic or with colorectal cancer have metastatic disease at diagnosis, and we call that synchronous disease. And another 20% will develop metastatic disease after their initial curative treatment, and we call that metachronous disease. That's how we refer to that one. And this is data based off of a large Dutch population-based study, which is, again, showing that most of the metastatic sites in patients with colon and rectal cancer include the liver and the lung. So we know that for some patients who have liver-only disease, surgical resection to remove the metastases may result in improved and prolonged overall survival. And this is largely based off of retrospective series. So on the left here is a combined MD Anderson and Mayo series showing that in patients who are eligible, resection of the liver lesions, those patients had improved survival compared to those patients who weren't eligible for liver resection. And as I mentioned, most of these are retrospective series where patients have been treated at a single institution, and those outcomes are reported as opposed to randomized or prospective trials. And so if you look at these articles here on the right, some of these series are very large, and it showed very promising 5-year survivals of 40 and 50% in these patients. There is very limited prospective data, but really the only randomized trial showing a benefit to local therapy for patients with liver-only metastasis is the EORTC 40004 trial. And this included patients with unresectable liver-only metastatic colorectal cancer. They had less than 10 metastatic liver lesions, and patients were randomized to either just systemic therapy versus local treatment, so radiofrequency ablation with or without surgical resection, plus systemic therapy. And what they saw at long-term follow-up was that there was an improvement in overall survival with the addition of local therapy in addition to chemotherapy. So more recently, there was the collision trial. So as we know, surgery, when possible, is the preferred treatment for patients with colorectal liver metastases. We know based off the collision trial at ASCO this past year that thermal ablation is an alternative for small colorectal liver metastases, so tumors that were 3 centimeters in size or less. And this is a non-inferiority trial that compared resection to ablation for these small-sized colorectal liver metastases. So it showed that ablation was less morbid, with no difference in local control or distant tumor progression-free survival rates compared to surgical resection alone. So in the entire picture of the management of colorectal liver metastases, what is the role of SBRT in addition to these other therapies? So a couple different ways we consider using SBRT and incorporating SBRT into the management of patients with colorectal liver metastases. One is in combination with other modalities. So this is a patient that I treated in this lower left-hand panel, where this patient had multiple liver metastases, underwent resection as well as ablation, and then we did SBRT to this larger kind of posterior liver metastasis that the surgeon didn't think that they could resect. So that was in combination with other treatments. Also can be used in difficult to reach places surgically. So tumors on the liver dome, sometimes those are difficult to treat with ablation. Sometimes they can be a little bit more challenging with resection if it's in the back part of the liver. And so this is a patient that we treated with SBRT because of that reason. And also patient preferences are due to patient comorbidity. So this is an older patient who thought about potential other more invasive options, but really felt that SBRT was the best option because it was the least invasive option. And I'll talk more about why that is the case. Here are some select studies that looked at the use of SBRT for the management of colorectal liver metastases. These are 5 different studies, fairly small numbers in terms of patient numbers. These are all retrospective series, so patients that were treated at a single institution and the results reported. You can see the different doses of radiation used in different treatment schedules. The 2-year local control is quite good, so it's 74% up to 91% with low rates of side effects or toxicity. Kind of changing gears a little bit and talking about lungs, metastatic colorectal cancer to the lungs. So again, very limited prospective studies to support the use of this treatment. There was this multi-center prospective UK trial called the POLMIC trial, which randomized patients to either pulmonary metastasectomy, so surgical removal of the lung metastases versus just continued systemic therapy. And what it showed is that there was no difference in overall survival between the patients who underwent surgery versus those who continued on chemotherapy. Now, again, the study was a smaller study. It didn't meet its full accrual, but showed that in this case, surgery didn't really improve outcomes. However, there's conflicting data. So MD Anderson published a retrospective series about 6 years ago or so that showed that in patients who had recurrent rectal cancer with lung-only metastatic disease, if they underwent curative surgery, that was associated with improvement in overall survival versus patients who weren't able to undergo curative surgery. So retrospective data shows that there may be a benefit. The prospective evidence that we have up to this point doesn't necessarily show a benefit, although, again, the study wasn't completed and had smaller patient numbers. So when do we consider radiation for colorectal lung metastases? So again, in combination with other modalities, so this is a patient on the lower left where we used SBRT in combination with surgical resection to treat all the lung metastases. When surgery might not be an option, so this is a patient where surgical resection wasn't possible for all the lung metastases. Then also patient preferences or comorbidity. So again, this was an elderly gentleman that had a solitary lung metastasis and wasn't interested in more invasive options, and so SBRT was a good option for that gentleman. Again, looking at some of the studies that have been published looking at the use of SBRT for colorectal lung metastasis. This is just 5 selected series that I found. Again, some of the patient numbers are lower, some of them are higher. This is a multi-center study that included over 500 patients. You can see the 2-year local control is anywhere from 60 to 83%. Again, low levels of side effects or toxicity. So again, a well-tolerated type of treatment for lung metastasis. So kind of the background information. Now I want to go into a little bit of a radiation therapy overview. So first I want to talk about how does radiation work? So radiation works by interfering with the DNA of tumor cells. So as X-rays interact with water in the tissues and form free radicals which bind to and damage DNA. So whenever cells try to divide and grow, they can't, and this results in the cells not being able to divide and ultimately in cell death. Just of note, tumor cells or cancer cells are more susceptible to radiation because they don't have the DNA repair machinery that most normal tissues do have. So what's special about SBRT or SABR compared to other types of radiation or more traditional types of radiation that we typically talk about? So first, I wanted to get a couple definitions out there. You'll see SBRT referred to as stereotactic body radiation therapy. You'll also see it referred to as SABR or stereotactic ablative radiation therapy. So these are just 2 names for the same thing, just 2 different acronyms. So SBRT, the reason why it's special, it's non-invasive, it's an ablative treatment, so it's a high dose of radiation. We use close margins around the tumor, so it's an extremely precise treatment. It's typically delivered in a few fractions, so 5 fractions or treatments or less. And compared to typical radiation therapy, it's a high dose of radiation therapy per individual treatment. So the idea is to deliver such a high dose to a small volume that you ablate or totally kill the tumor. So other reasons why it's different. So just to give an example plan of SBRT to a liver metastasis versus this is a pelvic treatment for a rectal cancer. So with SBRT, it's a relatively smaller volume. It's highly conformal to the target. You can see that it's the really tight margins, and it's a relatively higher dose of radiation per treatment. With conventional treatment, they tend to be larger volumes. It's not necessarily as conformal to a target. It has a little bit more generous margins for the day-to-day setup, and it's a lower radiation dose per treatment. So other radiation jargon, just to get out there as well, that some people, some patients come in and ask about and kind of see on websites and kind of other literature or on their searches. So you'll see the terms 3D conformal or intensity modulated radiation therapy or volumetric modulated arc therapy, so IMRT or VMAT. So 3D conformal and IMRT and VMAT, these are both radiation therapy techniques. Both of them can be used to deliver SBRT. It's just a particular radiation technique. So it doesn't necessarily mean that if you get 3D that you're not getting SBRT, or that they're using IMRT, you're not getting SBRT. Either one can be used to deliver SBRT. So that's a common question that people ask based off of their searches. Another question is, how do we determine what radiation dose to use? So sometimes in your patient chart, you may see the terms gray as the unit of measures. That's the unit of radiation dose that we use to measure how much radiation we're delivering. 1 gray is 100 centigrade, and the dose from 1 centigrade roughly equals 1 CT scan. Now, of course, these treatments are very focused with very small margins, and so it's not a full body dose. And treatment is delivered over a number of treatments or individual fractions is what we refer to them as. So the dose that we use to treat with SBRT depends on a couple things. So one is the goal of treatment. If it's a curative treatment, we generally deliver higher doses than if it's a palliative treatment or palliation of a symptom. Depends on the radiation sensitivity of the tumor and also the sensitivity of the surrounding normal tissue. So we have an idea of what the radiation sensitivity of adjacent normal tissues are, and so we customize the dose based on that as well. And so really the way that we know what doses to use for SBRT, it's really born out of running clinical trials and completing clinical trials to figure out what doses are effective versus what doses aren't effective. So now I just want to go through step by step the SBRT process. So the first process, just like any other medical procedure, we first meet with a radiation oncologist and have a consultation. So we do a history and physical exam. We talk about radiation therapy treatment options, come up with an overall plan. We may order additional labs and scans based on what's already been done. And if treatment is indicated, we will schedule something called the CT simulation, and that's a specific date and time that you'll come back to do the planning process for radiation treatment. So the next visit is the CT simulation. This is when the patient is placed in a reproducible position for daily treatment. And the idea is to have the patient in a reproducible position, but also in a position that's comfortable, so that the patient can lie in that position for 20 to 30 minutes. And the CT scan is obtained, and the idea is to really build a 3D model of the area of interest that we can import into a planning software that we use. And sometimes these scans are accomplished with intravenous and oral contrast. And we often make setup marks on the skin. A lot of times these are done with like a more permanent Sharpie type of marker, but sometimes tattoos are also used for these setup marks. Setups vary from institution to institution or from treatment site to treatment site. And sometimes you'll be lying on a beanbag type of device that really kind of fits around the body to kind of really get you in the same position. Sometimes there are immobilization guardrails or guide rails that kind of keep your legs in place. Sometimes they also will wrap you in a saran wrap type of material and your lower body and legs. And the idea is to kind of keep you in the same position every single day because the treatment is very, very precise with very, very low margin of error. The other kind of challenge with SBRT that we don't necessarily consider with some other types of treatments is internal organ motion. And so that's something that we, particularly in the liver and the lung, that we spend a lot of time thinking about and worrying about it and taking into account whenever we design these types of treatments. So the challenge with this type of treatment is that you're having to hit a moving target. So as you breathe, the liver moves up and down, the diaphragm is moving up and down, so the liver is moving up and down. The lungs, tumors in the lungs are moving. So we account for this motion in two different ways. One way is to gate the treatment or only treat during a certain part of the respiratory cycle. We refer to this as deep inspiration, breath hold, respiratory gated treatment. And the way we do that is there's a small block that's placed right below the rib cage, which is able to track breathing motion because of an infrared camera kind of anchored at the bottom of the table. So we ask the patient to hold their breath, and then we only treat during that part of the breathing cycle. So typically this is 15 to 30 seconds at a time for patients who are able to hold their breath. If you can't hold your breath, then we have an alternative method, and that's abdominal compression, where we put this kind of overgrown blood pressure cuff right below the rib cage, and we put air in it to restrict how much you're able to breathe in. So patients are still able to breathe in, they just are breathing more shallowly. And the idea is that you're limiting the motion of the liver. And if you're limiting the motion of the liver, you're able to treat less normal liver with a margin. And so the whole idea is to treat the least amount of normal tissue as possible and really try to focus on the tumor the best that we can. The other thing that we'll sometimes use is a fiducial marker. So this is the planning CT. So you can see things are pretty crisp and clean on that CT, but this is a CT that we get at the treatment machine. So because of the machinery that's used on the CT, on the treatment machine itself, the images aren't necessarily as clear. And so one of the ways that we can kind of track the target a little bit better is by implanting a fiducial in the tumor to help with improving the accuracy of treatment delivery. And so this is an invasive procedure. It's not always possible depending on the location of the tumor. The fiducial markers are made of different materials. Sometimes it's like a gold seed type of material. There are other fiducial markers as well made from different types of alloys. And the use of fiducials kind of varies between institutions and where the tumor might be located, but isn't always used depending on the situation. So after the CT session is all completed, the scans are done. The scans are then imported into the planning software, and it's turned over to the radiation oncologist. The radiation oncologist, so one of the things that I do is I go into the planning software and I say, okay, the tumor is here. So I highlight that area. I then look at the motion of the tumor, based on the CT scan, depending on which series that we get with the CT's imaging. And then I put a margin around the tumor as well to take into account the day-to-day setup. And then I draw the normal organs around the area as well. And the whole idea is to help the computer program figure out, what's the target and what are we trying to spare. Once I have all my areas drawn, I turn these contours over to a specialist in treatment planning called a dosimetrist. So the dosimetrists use computer software, and their job is to develop a radiation plan that meets the radiation dose that I want the tumor to be treated to, but then also minimize the dose to the normal tissues surrounding that tumor. So the idea is to maximize the dose to the target, the tumor, but minimize those to the adjacent normal tissues. And so the dosimetrists use specialized software with optimization algorithms to come up with a way and come up with a treatment plan that meets these objectives. Once that plan is ready, I review the plan. If I like it, I approve the plan. If it needs some modifications, I go back and work with a dosimetrist for those modifications, but ultimately come up with a plan that we like, and that plan is approved. The other thing about radiation oncology is that it's very much a culture of safety. And so really across the discipline or the specialty, patients before they start treatment are really reviewed in a multidisciplinary setting in the radiation oncology department. So prior to each patient treatment start, we review each individual plan with our entire team. So that includes radiation oncologists, radiation physicists, medical physicists, and dosimetrists. And review each and every plan, see if there are modifications that need to be considered, make sure that everything is in order, and make sure that the plan looks good moving forward. Once that's done, we're ready for treatment delivery. These are just a couple snapshots of our own institution. So this is the door to the treatment room. The radiation therapists are sitting outside of the treatment room, and they're managing the machine from this treatment console. There are microphones and cameras that they're able to view the patient and help with any issues that may arise, and also make sure that treatment is going smoothly. So this is actually a movie of just the gantry room and the machine rotating around a mock patient. So this is one of our physicists who agreed to lay on the table to demonstrate how this works. But essentially, the patient will set up on the table in the treatment position. Oftentimes, depending on the treatment, oftentimes they may have their shirt off or their pants pulled down slightly to see the setup marks and to be able to see the skin marks for the setup correctly. And the machine will rotate around the patient. You can see it's about 2 feet above the patient or so. The patient's in the room by themselves. Typically, for these SBRT treatments, it typically takes between 20 and 30 minutes per day. The majority of that time is spent getting the patient set up correctly, and the treatment is relatively short. Typically, the treatment takes between 5 and 7 minutes. So most of the time is ensuring that the patient is set up correctly, and imaging is acquired before each treatment to ensure that the setup is correct. So we also will see patients weekly during their treatments. These are called different things. We call them on-treatment visits. And the main goal of these is to assess for any side effects, any toxicity of the treatment. We kind of elicit a history, do a physical exam. We may draw labs depending on how things are going. Often may prescribe some new medications based on the symptoms that the patient may be experiencing. There are other radiation treatments as well, and I wanted to talk about 2 of them quickly. So one is MR-guided adaptive radiotherapy. So most radiation therapy, it's linked to the CT scans, and CT scanners are how we acquire the planning session images. There are special MRI linacs where the images acquired for planning are actually MR images. So there's an MRI attached to the linear accelerator. And the real advantage of that is that you can see the soft tissues and organs better. So if you look at this images here on the left, this is a left-sided liver tumor, right up against the stomach. You can see the tumor really well. The other advantage of this machine is that it permits real-time target tracking. It also allows treatment adaptation in basically each day of treatment. And so if the patient comes in one day and the stomach is a little bit fuller compared to the day prior, the radiation oncologist can actually put together a new plan and deliver a new plan that day. And so you can adapt depending on the changes in anatomy. So this is something that's exciting in our field and really learning how to use this better. Other thing I wanted to talk about just briefly is particle therapy or proton beam therapy, which is becoming kind of more common in the US as well. So the real advantage of proton beam therapy is essentially a dose distribution advantage of the radiation. So as you can see in the picture, protons result in less kind of low to intermediate dose for the normal liver compared to photons, which is what we typically are using. So the red is the high dose, the yellow, green, and blue is the lower dose. You can see with protons, there's no exit dose. It's a heavy particle. So you're able to spare more normal liver compared to the photon SBRT. The disadvantage is primarily cost. And so getting insurance coverage can be problematic. But ongoing studies are looking at the utility of proton beam therapy for SBRT, not necessarily for colorectal cancer, but maybe in the future. So after you finish treatment, we typically will schedule follow-up appointments. Typically, it's within 2 to 4 weeks. We do a history and physical exam, may also draw labs. Repeat imaging, including CT and MRI scans, may be obtained typically 1 to 3 months after finishing treatment. Depends on the clinical situation. It does take a little while for the normal liver, the lungs, for the inflammation to kind of calm down from the radiation treatment. So typically, it's a little bit longer than a month that we get our first imaging assessment. It really kind of depends on the situation, the clinical situation. So some of the side effects during treatment for liver SBRT. So these are the more common things. Depending on location of where we're treating, sometimes nausea or vomiting can be a side effect. A lot of times this is managed very, very easily with taking medications, so nausea medications before treatment each day. By doing that, you're able to kind of really prevent any nausea. Depending on the tumor location, sometimes you can have diarrhea. Fatigue is common during treatment. Usually when I describe fatigue, it's more like you're taking naps in the afternoon or going to bed a little bit earlier than normal. Reduced blood counts can also happen, so that's something that we consider and check potentially during treatment. You can have a little bit of skin irritation in the treatment field. You may have a little bit of skin redness. The chance of getting a horrible blistering sunburn is pretty low in general. It really depends on where the tumor is located. Tumors kind of closer to the surface of the chest wall are the ones that tend to have more skin irritation. So less likely is to have chest wall pain or a rib fracture. Sometimes you can have that depending on where the tumor is located. If it's right up against a rib and you're delivering a really high dose, it is such a high radiation dose that it can actually cause chronic chest wall pain. Chances of that happening are lower though because of steps that we take to kind of minimize that. Then much less likely is damage to any adjacent bowel that would require surgery, or liver or kidney damage that would result in a decline in function or spinal cord injury. So those things are just much less likely to happen just because of the meticulous radiation planning. For lung SBRT, some of the side effects. So again, fatigue is common. Skin irritation in the treatment field can also happen depending on where the tumor is located in the lungs. More likely for kind of tumors on the edge of the liver, or on the edge of the both in the liver and in the lungs. Less likely is cough or difficulty breathing, fever, or chest wall pain from the treatment. And then much less likely, again, depending on the location, if the tumor is right up next to the heart, damage to the heart, or if it's next to the esophagus, narrowing, bleeding, or ulceration of the esophagus. If it goes up next to against the vessel, damage to large vessels around the heart, or any bleeding of the airways, skin ulceration, again, rib fracture or spinal cord injury is just really unlikely. So anytime it's close to an organ that we really worry about, so we really take that into account and may change the dose that we're delivering to the tumor. Excuse me. So now switching gears a little bit. So primarily up to this point, I've been talking about liver or lung confined metastasis. So we know that there's a benefit to metastasis-directed therapy in this patient that has a solitary liver metastasis. But what about this patient? So this patient that has a right upper lobe lung metastasis and a left lower lobe lung metastasis and a right liver metastasis and a retroperitoneal lymph node metastasis. Is there a benefit to local therapy in that patient? So we actually did a survey of the experts this year where I surveyed 47 experts in medical oncology, radiation oncology, and surgical oncology. experts in the management of metastatic colorectal cancer. And I asked questions about when they would consider offering local therapy like surgery and radiation and ablation, depending on some example patient scenarios. And this is a busy figure. This is really kind of the crux of the paper. So I asked about kind of two different scenarios. I asked about patients who develop metastasis 6 months after finishing their definitive or curative treatment versus 36 months after definitive or curative treatment. Then I presented different patient scenarios, so different distributions of liver metastases, different distributions of lung metastases, and then retroperitoneal lymph nodes as well, or abdominal lymph nodes. And you can see by specialty, so the medical oncologists versus the radiation oncologists versus the surgical oncologists. So the surgical oncologists were really, really willing to offer local therapy to a lot of patients with larger burdens of disease compared to medical oncologists. Medical oncologists were fairly stingy in when they would offer local therapy, and radiation oncology was kind of in the middle. I asked more questions about the number of metastases that they would consider local therapy for, including patients with liver-only disease in one lobe, liver-only disease in both lobes, or lung-only disease in one lung versus both lungs. You can kind of see, again, the number of lesions that medical oncology would consider local treatment for compared to surgical oncology. So medical oncology was much on the lower end, 3 lung lesions, compared to surgical oncology was consistently at the very high end of the scale. So that really led to the development of the ERASER trials. This is a pragmatic trial that is currently ongoing in the cooperative groups, looking at the role of local ablative therapy and total ablative therapy in patients that have limited metastatic colorectal cancer. So it's A022101 or NRG GI009, is also known as the ERASER trial, and it's a trial that I'm co-leading with Dr. Hitchcock and Dr. Romisser from NRG Oncology. I'm the study chair from Alliance. So currently, this is really the only first-line metastatic colorectal cancer trial available for the majority of patients in the cooperative groups right now in the NCI. And just to kind of walk through the schema a little bit, so it includes patients with newly diagnosed limited metastatic colorectal cancer that have 4 or fewer sites of disease on baseline imaging. And I'll talk in a moment about what that means. The primary tumor must either be resectable, already removed, or able to have a complete clinical response after treatment. That's primarily of course, for rectal cancer patients. It needs to be BRAF wild type or microsatellite stable, and patients can't have liver-only disease just because there's already a standard of care for that patient group. So patients receive induction systemic therapy for 16 to 26 weeks. If patients progress, again, they would not continue on the study because they would really start a second-line chemotherapy option. Then patients would then be randomized to either continue standard of care systemic therapy or with the addition of total ablative therapy to all metastatic sites. And total ablative therapy is SBRT or SABR, surgery, and microwave ablation, or any combination of those. And the primary endpoint of the study is overall survival. So patients can enter the study at a couple different time points. They can pre-register for the trial before they start any chemotherapy, or really any time up until 6 months of systemic therapy, they're able to pre-register for the trial. They can't have peritoneal or mental metastasis, and they must have measurable disease on their baseline CT scan. They're allowed to register for the trial, so actually be randomized and register on the study after a minimum of 16 weeks of systemic therapy and a maximum of 26 weeks. And any prior definitive therapy, so if you were to have rectal cancer and had chemotherapy and radiation and then surgery and then adjuvant chemotherapy, you have to have had prior definitive therapy completed at least 12 or more months prior to the metastatic diagnosis. There needs to be a 12-month gap between finishing your adjuvant chemotherapy and then that metastatic diagnosis. And just a quick note, I'll go through it in a minute, but we just passed an amendment to kind of open up the window for some of these, but I'll talk about that in a minute here. Here's how we're defining a metastatic site. So it's 4 or fewer apparent sites of metastatic disease. And so the tumor lesions must be treatable with any combination of surgery, microwave ablation, and SABR or SBRT. And a single site includes each hemiliver, so each right and left liver, hemilivers is a single site. Each lobe of the lungs is a site. Each adrenal gland is a site. So lymph nodes that can be surgically removed in a single surgery or treated in a single SBRT field is one site. Then bone metastasis that's amenable to treatment in a single SBRT field is also one site. And just importantly, there are no restrictions on the number of lesions per site. And so, for example, this patient that has 3 lesions in the right upper lobe, that's one site. 3 lesions in the right liver is one site. 3 lesions in the left, or 1 lesion in the left upper lobe is one site, and 1 lesion in the left lower lobe is one site. So this would be considered 4 sites of disease. So again, no restriction on the number of lesions per individual site. So one of our goals for this study is to make the study as practical as possible. And to do that, we really have allowed pretty much anything that you would get normally on the study. So for the control arm, if you're randomized to continue with chemotherapy, you can continue with chemotherapy. You can use maintenance or de-intensified chemotherapy based on discussion with your doctor. Chemotherapy breaks are permitted at any time, just again, after discussion with your treatment team. You are allowed to do radiation. We ask that non-ablative radiation regimens be used. Obviously, if you have other things that are not being controlled medically, so if you have a bleeding primary tumor that needs removed, that absolutely can be removed surgically. Again, no issues with that at all. In the experimental arm or the TAT arm, we ask that that be completed within 90 days of randomization. At least one site needs to be still present after completing chemotherapy, so there needs to be something to treat. And then after finishing the total ablative therapy, we consider restarting chemotherapy 2 to 4 weeks after finishing that treatment. And again, allowing maintenance chemotherapy or de-intensified chemotherapy, again, after a discussion with your treatment team. Also allowing chemotherapy breaks at any time at the discretion of the treatment team. And for patients who still have the primary tumor intact, we ask that it be removed within 6 months of randomization. Or if it's a rectal cancer, you can also have chemotherapy and radiation. And if you have a complete clinical response, the tumor does not need to be surgically removed. So we're allowing non-operative management as well. So here's a quick study update on where we are with this study. It's approved at 110 sites currently in the US. There are 8 patients who have been registered and randomized. We have 19 patients who are kind of waiting to be randomized. They're getting induction chemotherapy right now. The study opened in January of 2023, so it has been a little bit slow to accrual. So we do ask you to continue to keep the study in mind and consider it if you're a patient that would potentially qualify. Always happy to help. Feel free to reach out at any time if there's anything that we can do to help. We did just pass an amendment. It's going to be pushed out to sites hopefully within the next 2 weeks. It helps take down some barriers that some of the sites have been asking about or have reached out about. One is that we were requiring a metastatic site biopsy initially. So we've removed that, so you don't need to have a metastatic site biopsy. Biopsy from the primary site is totally fine. Just need to have a pathologic or a biopsy diagnosis that shows that you have colorectal cancer. We also moved that metastatic site requirement, so that requirement for 4 or fewer sites of disease, removed it from the pre-registration to the registration phase. So essentially what that means is that you don't necessarily need to have 4 or fewer sites of metastatic disease initially. So you can have even more disease whenever you're first diagnosed. And after you have finished induction systemic therapy, as long as you meet that 4 or fewer sites of disease requirement prior to randomization, you would be eligible for the study. So that hopefully opens up the study to more patients as well. We've also increased the range of allowed systemic therapy before randomization to 12 to 39 weeks. So before it was 16 to 26 weeks. Now it's as little as 12 weeks and up to 39 weeks. So again, for patients who don't necessarily want to do 4 months of chemo, you can actually stop now at 12 weeks as opposed to 16. And also increasing the upper range of that as well for patients who may have just missed the window and want to get on the study as well. We also decreased the window of the prior definitive therapy. Instead of it being 12 months from the completion of definitive therapy, it's now 6 months. So you can finish your definitive treatment if you develop metastatic disease within 6 months or 6 months or after, you're eligible to participate in the trial. And finally, initially we did require SBRT be used for the treatment of at least one site. Now we've really just kind of opened it up to allow treatment teams to really determine which therapies that they want to use for total ablative therapy. So it's really up to the treatment teams to do whatever they want and whatever they think is best for managing your metastatic colorectal cancer. And of course, we're always available to help consult with those teams as well and are in regular communication with each of the sites in the US. through email and other means of communication as well. So we're engaging with our study champions and really thank the Colontown patient advocates and their team. They've been instrumental in getting this trial up and running and continue with their support. We really, really appreciate that. Definitely wouldn't be where we are without their support in getting this trial up and running. We are doing informational webinars kind of nationally. The next one is planned for early next week to kind of talk about the amendment with sites and get the word out about that. We also send out monthly newsletters to sites to provide updates. And then we're working on patient recruitment materials as well to kind of help from the patient recruitment end as well to get the word out about the study. So that was all I had planned, but happy to take any questions. Again, you can always reach out to me at any time with my email address. Definitely happy to help in any way that I can. And yeah, really thankful for the opportunity. So happy to take any questions. Thanks again.
So thank you so much. This has been fabulous. I've learned so much. So thank you. And you do have quite a few questions here in the chat. So I'm just going to go ahead and get started on those with you. And if I mispronounce something, you can just laugh at me. That's okay. So there is a lot of conflicting information about how many times SBRT can be repeated. Could you please clarify that?
Yeah, it's a great question. It really depends on location. So if you're treating a new location, it's really not an issue. So for example, I think I can go back and pull up a patient image real quick here to give an example. So you can use this image. Yeah. So for this patient on the left here, for example, so for this area right here, treating this area right now, we can go back and we can treat another area over here. We can treat an area over here. It kind of depends on two things. So one of the things is overlap with prior treatment. And so each kind of organ in the body has a lifetime radiation limit that it can tolerate. And so anytime that we go back and do radiation a second time, we have to be very conscious and very thoughtful about what the prior area received. So if you have something like right up next to the stomach, and now you're treating something right next to the stomach again, you have to really be conscious of what the dose is to the stomach. The second thing that you have to really think about is what is the cumulative dose to the liver? And so the liver also has a lifetime limit of radiation that it can also tolerate. And so you can't go back and treat the liver again and again and again. It has essentially a tolerance also. So you really have to kind of take it on a case by case basis and kind of think about each individual treatment and then also the treatments as a whole. The analogy that I use with patients when I describe it is it's like having liver is like having a jar, and the jar is full of coins. And every time that you do a treatment, you're making a withdrawal from the jar, and the jar isn't necessarily filling back up very quickly. So some of these treatments, depending on the location, can be a small withdrawal or a large withdrawal. But it's really just a case-by-case basis, taking into account where the treatment is, what's the cumulative dose to the liver, and kind of making sure that you're not, you're staying within the limits of both of those.
Thank you. And I would assume it's the same for the lung?
It's true. Yeah, it's the same for the lung. Yep.
Okay. Can SBRT be done consecutively while on chemo, or is there a downside to that? For example, done on some stable lung meds for a person also dealing with a few small liver tumors, so still on chemo.
Yeah. So a lot of times what we'll do is we will kind of sneak in the treatments in between chemo sessions. So one of the things that we'll commonly do is if a patient has, let's say that they had, 3 or 4 liver metastases up front and they get chemotherapy, let's say two of them are remaining, the other two resolve. So there's only 2 spots left. If we think about radiation and we think that's the best modality, kind of depending, you can actually do the planning session while on chemotherapy, get the plan all ready to go, and then deliver the radiation kind of in between chemotherapy sessions. Typically, it also kind of depends on which chemotherapy that you're getting and where the tumor is located. We don't really like to overlap with Avastin, depending on kind of where the tumor is located, especially if it's around like the stomach or like the bowel. But if it's FOLFOX, if it's FOLFIRI, you can kind of, get chemotherapy, get a week off, do radiation that following week, have another week off, and then kind of re-go back and start on chemotherapy again. So you can kind of fit it in between chemotherapy cycles.
Has proton radiotherapy been shown to have superiority over photon radiotherapy when used in SBRT?
Yeah, it's a great question. So the answer is no. We don't have any like randomized trials showing that it's superior. There is some data. It's not in colorectal cancer. It was in primary liver cancer, showing that at least in patients with that type of cancer, that whenever you're using SBRT, you are able to spare a more normal liver and may reduce the chances of developing liver failure kind of down the road. But we don't have level 1 evidence right now that shows that protons is superior to photons.
For a recurrent colon met of about 1.3 centimeters on the liver near the surgery cutting edge, would you recommend to treat with radiofrequency ablation or SBRT?
Yeah, it's a good question. I think if it's a small tumor, I think if liver function is fine and they're able to get it with RFA, I think that might be like my go-to first, and maybe keep SBRT as a backup option. If they're not able to ablate it, sometimes, depending on the interventional radiologist, I know we talked to ours a lot about this. Sometimes if it's on the liver edge, or like a peripheral tumor, depending on location, sometimes they have a hard time getting to it and ablating it completely. So if they feel like they can, I think I'd probably favor RFA first and then maybe SBRT after, if if they can't treat it or if it recurs.
My son is post liver transplant, 2.5 years, now has a 1 centimeter lesion on one lung. The oncologist is referring us to a pulmonologist. Should he go to a radiation oncologist first?
Is that the only area of disease, if I may ask?
Yes.
Um, I think it's fair to. It's probably going to talk to a thoracic surgeon. Is that right? Maybe.
Probably.
Yeah, I
She's
think. I mean,
probably going
I think still, if you can, I think, and if it's only the only spot, I think surgery is still really the gold standard. It has the best local control of any of the modalities at this point. I think if the surgeon feels like they can't remove it, or if they're particularly worried about comorbidities or the morbidity of this surgery, I think SBRT is a good option as a backup. Um, I think you can also go and talk to both and kind of make a decision based off of that as well. I encourage people to kind of talk to both, and then you can make an informed decision.
Can you talk about risks about radiation to retroperitoneal lymph nodes? The oncologist says the risk to nearby structures, but radiation oncologists are pro-radiating them. Is proton photon better?
Yeah, it's a good question too. So it depends on kind of where things are located. A lot of times with kind of more, with IMRT that I mentioned and VMAT, kind of more advanced radiation techniques, the photon treatment should be fine. It can be tough to get protons approved for metastatic disease, just because insurance doesn't want to approve them because it is a much more expensive treatment. But in general, you're able to kind of carve the radiation dose around the nearby organs, and it can be done safely and tolerated well. So I think it's a good option for those patients where surgical resection isn't an option and you're trying to maximize local control. So yeah, we see a fair number of those patients.
Any idea how many institutions have the LINAC, not sure what that name is, the MRI machine that you said for real-time SBRT?
Yeah, there's a number of places across the U.S. now that have the MRI based linear accelerators. If you if you message me, I can guide you depending on where you are geographically. But yeah, there's a number of them in the US now, and it's becoming more mainstream and being used more often. And the big advantage is, again, you can just see things so much better. You can target track in real time, and you can adapt, and that's really, really powerful for this type of treatment.
And I think you answered this one, but I'll just ask it again because it's here. Can SBRT be used for lymph node metastases?
It can,
Yeah.
absolutely. Yeah. Yep.
For these charts, where you were talking about when you asked the professionals, the other, the surgeons, the radiation oncologists, et cetera. So a patient was looking at those charts and
Yep.
asking, was age taken into account for these opinions? It's difficult to see.
Yeah, good question. No, whenever we asked the scenarios, we basically said it was a patient who we didn't give an exact age. We said it was a patient who was able to tolerate all interventions. So we said it was a a healthy patient that could essentially tolerate any of the interventions that would have been proposed, but no
And
age
one
specifically. Yeah.
one patient asked, do you need to be BRAF wild type and MSS or or either or for eraser?
So you need to be or either or. Yeah, you need to be BRAF wild type and microsatellite stable. Yeah. It if you know your status. I mean, most patients, it's part of the standard workup at this point, but yeah, if you know your status, then it needs to be, yeah, BRAF wild type and microsatellite stable.
Okay. Here's one. Do you utilize the ALIYAPEF system for ablation?
Uh,
ALIAPEF? I don't, I'm not familiar with that.
I'm actually not either. I'd have to get back to you about that one.
Okay.
Are you meaning for microwave ablation?
Yes.
Uh, I'm not as familiar. I would have to ask. But
Okay.
yeah, for this, is the question specifically about the study?
Yeah.
Yeah, we're only allowing microwave ablation, uh, and it's a long-winded answer for that, but essentially it needed to be an ablative technique where we could do good quality assurance and is standardized across institutions. And so microwave was uh, told by the experts. We were told by the experts that that's the one that we should do.
Okay.
Not sure if
Um,
question, but
have you had any success treating a solitary presacral or a sacral metastatic lesion? If so, is there any restriction on the size of the lesion?
um, have done it in the past. Um, I can't necessarily think of a size restriction. Um, in general, the bigger the tumor that you're treating, you're usually able to achieve, you're not necessarily able to achieve a as high a radiation dose as for a smaller tumor, if that makes sense. And a lot of it depends on what normal tissue is around the area. And so if you have a lot of times down in the sacrum, sometimes there will be small bowel that falls into the field. Or if there was prior radiation, you have to also consider that. So that kind of limits what you're able to accomplish either the second time around or if it's the first time around. But there isn't necessarily a size restriction on treating any of these. It may limit the dose that you're able to get into that area.
And one patient had asked, we couldn't have more than 26 rounds of chemo and then said, never mind. I see the answer says up to 39. I just want to make sure that that's correct.
Yes. So in the amendment, it's now 39 weeks of chemotherapy. So we didn't use cycles just because the cycles can be different depending on which chemotherapy that you're getting. So we counted it by weeks. So yeah, you're allowed up to 39 weeks of chemo.
Thank you. When would SBRT be used versus ablation for lung nodules and then for also for liver? So the same question, when would SBRT be used versus ablation for lung and then also for liver?
Yeah, so I think when I kind of think about I guess talking about liver first, I think surgery when it can be done is the gold standard. There's just nothing better than that in terms of local control. I think the collision trial really did show that for those smaller tumors, um, you know, ablation is really the same as surgery. There's really no difference. And so I kind of think of surgery and ablation maybe as being kind of on the same tier for the smaller liver metastases. Um, I think whenever you're getting into the situation where you're not able to ablate or surgically resect everything, or if the tumor is in a particularly tough location, like if it's right up next to a vessel that acts as a heat sink, they can't necessarily ablate it or surgically resect it, or require a really big surgical resection. I think that's really whenever SBRT kind of plays a role in the liver. I think also if some patients who have just had a surgery and don't necessarily want to go back in for another surgery, I think it could be a good non-invasive option for those patients as well. For lung nodules, again, I kind of think about it the same way. Surgery is definitely like the gold standard for lung if it's possible. Again, lung's a little bit harder because there can be like smaller little tiny nodules that may or may not be real, so you can't always go in and resect all of those. Ablation for lung nodules, I feel isn't quite necessarily as universally utilized as like ablation for liver. It's becoming more mainstream, but I don't think it's necessarily quite there yet. SBRT for lung is tolerated really well. It's non-invasive and it's fairly easy and straightforward. So I kind of when I think about both of those, I kind of think of them as being necessarily interchangeable. I mean, SBRT is non-invasive. It doesn't involve a big procedure. There's no, very, very low risk of having a pneumothorax. And so I think it's a good option for the lung.
How long of a washout do you need from Avastin for SBRT?
Yeah, nobody really knows the exact answer to that. We usually like to do at least like 2 months if we can. Um, we think the longer the better. That's not always possible. Um, on the trial, we really kind of require 6 weeks between the last Avastin and like a surgery or like an invasive procedure. But typically, I like to do 2 months between, kind of on either end of that.
After doing SBRT, if it does not work well, could ablation be followed for further treatment, given it's not good to do SBRT again?
Yeah, you can mix and match. Yep. And same the other way. So if ablation, you do that first and it doesn't work out, you can do SBRT after that too. So yes.
If you once showed very low peritoneal disease burden on scans, which was never biopsied, which is now no longer showing, could you qualify for the trial?
Yeah, it's a good question. Uh, technically it wouldn't qualify just because uh, yeah, we're not allowed to include patients with peritoneal disease, unfortunately. But I do sympathize that it's not was not biopsied, so not certain. It's a question if it's real or not, but unfortunately it wouldn't be allowed.
I think that Teresa, even if you don't qualify for the trial, maybe that's a conversation you could have. Um, still about maybe doing it in a different setting. So something to think about or talk about maybe at some point.
Yeah,
Um, so if a lung nodule is on a blood vessel, would that still be something that's treatable with something like SBRT?
yeah, yep, yeah. We're not really limited by that at all.
Okay. What is the lower size limit for lung mets? Is anyone at Mass General Brigham involved in recruiting patients for the trial?
Yeah, so for the lower size limit for lung mets, it's really what the radiation oncologist is comfortable seeing. Typically, it needs to be about a centimeter in size for us to be able to see it and target it. So you need to be able to see it on a CT. You need to be able to see it on the CTs that we get for treatment each day. Um, and so that's usually like the lower kind of limit for treatment is about a centimeter in size. So currently, unfortunately, the trial is not open at Mass General. Um, I really wish that was, but it's currently not. So if you know anyone that I could convince to get it open there, please let me know, because it would be good to have it at that site as well. But currently it's not open there.
Well, I know some folks there, so I can message you.
Yeah, let me know. We've been trying.
Um, are the typical side effects of SBRT comparable to chemo side effects?
Um, I would say no. So I think in general, patients tolerate SBRT really well with very few side effects. So I know I kind of went through all of them, but typically, what we typically will see is maybe some fatigue and some nausea that's pretty easily well controlled with taking nausea medications before treatment. Um, don't really have neuropathy from SBRT at all. Really don't have like the nausea a couple days later, like with chemotherapy. So in general, I think it's tolerated, you know, better than chemotherapy in general.
Here's one that I think you had said earlier you're not familiar with, or maybe I'm imagining that. Do you know what the ALIYA radiation is and how it's different? The ALIYAH.
Um, Let me see if I can, not off the top of my head, but uh, got it. Looks like it's actually an ablative. It's a pulse electrical field system. That's more of it's actually a ablation than radiation. Yeah, I'm not necessarily super familiar with it.
Okay, no worries. Something for me to follow up on. How does the stereotaxis of SBRT differ from that used in preoperative radiation therapy of the primary tumor?
Um, to make sure I'm understanding the question right. So basically, how do we localize things with SBRT versus for the primary tumor? If I'm interpreting that right.
Yes.
So
Trying to think of the MET versus the primary.
yeah, it's a little bit different. So with the metastasis, the setup is much more well, with SBRT in general, the setup is much more precise. We're using, we're controlling motion of the tumor. We're using smaller margins. We're delivering really high doses in a few treatments. And so a lot of time and effort is spent in kind of localizing that spot, minimizing motion to that spot, and really delivering a high dose to that spot. So for rectal cancer, for example, in the pelvis, um, we're delivering lower doses over the course of essentially typically 5 to 5.5 weeks to 6 weeks. And so there's not really a lot of motion there. You can be a little bit more generous because the day-to-day setup, you can be a little bit more forgiving because it's not as high a dose of radiation per day. And so it's just kind of two different thought processes whenever you're setting that patient up versus with SBRT. That makes sense. There's more forgiveness with like a pelvic rectal cancer treatment than there is with like an SBRT treatment where the stakes are a lot higher, fewer treatments, higher dose. Not that we're not what that we're like cavalier about treating the pelvis. We're equally kind of as cautious, but there are more treatments, there's less motion, so there's more room for movement and more room for day-to-day setup error, if that makes sense.
Okay, I think we just have two left. For multiple small lung mets, would SBRT be the preferred treatment or ablation since it can be repeated?
It depends on the situation. I mean, I think um, SBRT, I mean, you can also do SBRT, you can do multiple courses. Um, so if you have a couple areas in the lung, um, we do this all the time where a patient may have 2 or 3 lung spots. We treat those, and let's say 6 months later, they may have a couple more spots that they want another chemotherapy break, or a year later, you can go back in and treat those again. If they're not necessarily overlapping in the same spot, they're not right next to the heart or anything. So you can kind of mix and match modalities. And so there isn't necessarily one that's preferable over the other.
Okay. I didn't catch this, so someone is asking if the trial is available for KRAS mutant patients also. Do you know, because BRAF, no, but KRAS?
KRAS, yeah. Yep.
Okay. And then she's talking about how her daughter has a pump, and can this be given at the same time as FUDR through an HAI pump?
Now let's see. Going down to that one. Okay, so can you do SBRT with the pump?
Yes.
Yeah, you wouldn't want to do it whenever they're actively using the pump. But you can do SBRT if a pump's in place, if that's the question.
Okay.
Yeah.
And then I think, let's see, can the same lung nodule be treated twice with SBRT?
It can be. It depends on location, and kind of what's around there. But I never say never. You have to just be careful, kind of review the where the new area is with the doctor, and kind of see what they think. But I never say that you can never do it. You just have to maybe be more careful, or may consider a different modality. But
Okay.
it's possible.
Is there a limit to the number of lung mets that can be treated with SBRT at the same time?
Um, there is a limit. And what that limit is depends on who you talk to and where you go, and a lot of it's like, institutional based, as opposed to being a hard and fast rule. Um, I guess personally, I've really kind of limited mine to maybe like 3 or 4 spots all at once. Um, but there's not like an official rule that you can limit it to a certain number. You just have to kind of keep in mind that um, if you have a lot of spots and you treat all those areas, there's a higher chance that there could be more spots the next scan. And so you have to kind of think about what the goal is, and what you're able to do, and what how effective that treatment's going to be, if there are that many lung nodules, if that makes sense.
Great. I only see two more, so we'll just take these last two and then we'll wrap up. Someone's asking about SBRT versus Y90. That's a good question. I'm actually really curious about that.
Yeah, it's a good question. So um, it really depends on the situation. So um, we do both. I do feel like SBRT is more of an ablative type of treatment, as opposed to Y90. Um, you can use Y90 as an ablative type of treatment. I think for at least for colorectal liver metastases, I think SBRT is I kind of favor that over Y90, just because if you have like 1 or 2 spots, you're able to really focus in on those spots and deliver a high radiation dose. With Y90, in order to do ablation, you need to be able to localize that target. You need to be able to, make sure that you find a vessel that treats that individual tumor. And if you can't target that tumor, then you can't deliver a high dose to that segment that is feeding that particular part of the liver. So I feel like SBRT is a little bit more versatile because of that. So you're able to kind of localize targets and treat them, as opposed to Y90. You're really kind of dependent on the vascular supply, and whether or not you can isolate that vascular supply to the tumor. I also don't know that the data is necessarily there for Y90 as an ablative modality compared to SBRT. I mean, really, the best data that we have for oligometastatic disease is with is really with, surgery, ablation, and SBRT at the current moment.
And then I think the last one is about, can a patient be on Erbitux and Xeloda and still get SBRT? There's a MET in segment 2 that they're interested in getting looked at for SBRT or radiation.
You can, you would have to be off of it temporarily. I wouldn't do it at the same time. You'd have to be off of it for at least like a week in between treatment. Yeah, you wouldn't do it concurrently.
And folks are asking if you can go to the slide with your contact information on it.
Oh, yeah. Yep.
And then let's see. I think I'm just gonna ask this one and let you go because I feel so bad that we've run a little bit over here, and I appreciate your time.
Oh, no problem.
You mentioned that effectiveness for surgery and ablation are kind of the same now. How about SBRT?
Yeah. So specifically for liver and lung metastasis,
It
we don't
doesn't
really,
doesn't
yeah,
say liver or lung.
yeah, but just thinking about it a little bit. So, we don't have the head-to-head comparison of SBRT with surgery and RFA. If you look at the numbers, it is an effective treatment. Is it as effective as surgery? I think surgery is, I mean, it's just the ultimate local control for these types of tumors. RFA for a small tumor, I think RFA and SBRT are probably fairly equivalent. Now that trial doesn't exist, and so that's really kind of pure speculation. Um, but that trial doesn't exist, so I can't say that they're exactly the same. If you look at the numbers, I think the numbers are pretty comparable, but we have never done a head-to-head comparison of them for colorectal liver metastasis that I'm aware of.
Great. And one question about the study. On the completion of your study, you are rendering your overall survival 2 years, 5 years, et cetera, or disease-free survival. Can you render in age groups? As often I see charts, but they do not differentiate age groups. And I feel there may be value in showing results based upon age, disease progression, treatment, overall survival.
Yeah, for the eraser trial.
Yeah.
Yeah, it's definitely something that we would think about and consider for sure. Yeah, including age as one of the variables that we look at, and looking at how the treatment, how it is effective based on patients of different age groups is an important thing to consider. So yes.
Thank you. And then I think there's just a lot of thank yous for you in the comments now. And I want to echo that. Thank you so much for your awesome presentation, all the hard work that you put into it. It means so much to all of us, our patients and our caregivers. And we, of course, are excited to hear about the trial eligibility, opening up a little bit more for the study. That's exciting. And we'll continue to try to educate our patients and caregivers in Cullentown about the trial as well.
Yeah, thank you so much, Betsy. Thanks so much, everybody, for the opportunity to present. Really appreciate it.
Thank you so much. Good night, everyone.